I will now introduce our second speaker, who will be presenting on interpreting tests and investigations, a topic that is very useful in helping you to understand your results of your blood tests and scans and their role in diagnosing and monitoring myeloma. We have with us today Dr. Dipti Talaulika, who is a clinical and laboratory hematologist at Canberra Hospital with a clinical and research interest in lymphoma and myeloma. She is an associate professor at the Australian National University. She sits on the Medical and Scientific Advisory Group of Myeloma Australia and has published several myeloma guidelines. Welcome, Dipti.
Thank you very much, Emma. I'll just highlight the slides, then we can get started. There we go. I hope everyone can see the slides well. Thank you for having me, Myeloma Australia, and welcome to everyone who's on the talk. So I have been tasked today with telling you about some of the investigations that are performed for both diagnosis and monitoring of multiple myeloma. I thought I would start with a case. I find that a really good way to try and illustrate how patients would be managed. So Mrs. MM, she's a 72-year-old lady who presents to her general practitioner or GP for routine bloods. She's got no symptoms at all. ESR, which is an inflammatory marker, is elevated in her case, and she has a liver function test done as part of her routine investigations, and that shows that there is an increase in globulins. So normally, as part of liver function tests, you get two protein components that are listed. One is albumin and one is globulin. So the globulins in her case were increased. Now the GPs know that when you get elevated globulins, it can be a whole range of different conditions, including multiple myeloma. So normally they will order serum immunoglobulins. So they will check your IgG, IgA, and IgM levels. So in her case, she ends up having an elevated or high total IgG level. And when the laboratory put out the result for that, they suggested running additional protein studies. So there's a whole range of different protein studies that we can do, starting from a simple liver function test to quite complicated tests, which I will walk you through. And they also suggest referral to a hematologist. So Mrs. MM ends up going to a hematologist who then requests a whole range of additional investigations. Now, one of the first tests that's often done is a full blood count and blood film. So in this patient, the full blood count showed a low hemoglobin or anemia. And you may have heard by now that CRAB or hypercalcemia, renal failure, anemia, and bony disease, they are the hallmarks of end organ damage in multiple myeloma. So she certainly seems to have that feature there. What I've got here on the left is a picture of her of her blood film. So from the blood sample that is collected, we make a slide, make a smear out of it, and then look at it under the microscope. So these are the red cells in the background, these donut-shaped cells. You've got a tiny platelet there, and you've got a white cell. This, in fact, is a plasma cell, very hard to see in the circulation, but she certainly seems to have one cell, at least, that's visible on this field. Now, normally, the red cells tend to be quite nicely separated from each other, but in this case, you can see that they are stacked on top of each other, and that's caused by the high protein that patients with multiple myeloma tend to have. So it just makes the red cells a bit sticky and they tend to stack up on each other, and that's known as rouleau. The other thing that we often tend to see is if you just hold the slide up to light, you will find that there's a blue tinge to the film, and that's again caused by the high protein in the blood. So that's what we see on the full blood count and on the blood film. Now, the other two cardinal features, renal failure and hypercalcemia, can be assessed through basic biochemistry. So patients will have calcium levels checked. In her case, the calcium level was normal, but she did have a bit of renal dysfunction. So creatinine was high and eGFR was low. Now that could be because of other reasons as well. And I haven't told you yet, but Mrs. MM also has diabetes. So she has a bit of renal dysfunction because of that. So not all of these features are due to multiple myeloma, and hematologists have to sort of put the puzzle together by combining a number of investigations to decide whether a patient has multiple myeloma or not. Some of the investigations that really help us, so all of these so far that we've looked at are quite non-specific, but the specific investigations that help us to make a diagnosis are one, a bone marrow biopsy. So Mrs. MM went on to have a bone marrow biopsy, and on the right-hand side, you can see a picture of the bone marrow aspirate there, and it shows lots of plasma cells. So plasma cells are the key malignant cell in multiple myeloma. And normally in the bone marrow, all of us have plasma cells. We have them in usually less than 5% in the bone marrow, and they produce antibodies which help us, which protect us from infection. So we need those plasma cells there. But in multiple myeloma, they become malignant, so they're quite abnormal looking, and I'll walk you through that in a minute. But also they are increased in number. So in patients with smoldering and multiple myeloma, you would find at least 10% plasma cells in the bone marrow. In MGUS, you can have less than 10% plasma cells. So this is what the plasma cells look like. They've got a nucleus that's quite eccentric. So it sits, instead of in the center of the cell, it's sitting on one side of the cell. You've got this really blue cytoplasm, and you have this clearing around the nucleus, which is again quite characteristic of plasma cells. Now, how do we know that these are malignant? So some of them have immature features. So there's a clearing in the nucleus here that you can see. That's a nucleolus, tells me it's an immature plasma cell. And here you can see a binucleate form as well. So these are some of the features. So we look at the numbers, but we also look at the morphology of the plasma cells. Now, the other thing that really helps the hematologist besides the bone marrow is actually looking at additional protein studies. So in this patient, we established that she had high globulins on liver function test, and we also established that she had high IgG. Let's look at how we actually try and find the abnormal protein in patients with multiple myeloma. So we tend to do an investigation called serum protein electrophoresis, where we take a bit of the patient's plasma and we subject it to an electric charge. So you can see a picture there on the top panel under A. And based on the size and the charge of the different proteins, they will separate out after a period of time. So on the top panel, you can see albumin there, which is present in the most amount, and that's also demonstrated with quite a large peak. You then have your alpha-1, alpha-2, beta, and gamma globulins. If you look at the gamma globulins at the top, they are seen as a smear or a smudge. So that's a nice, normal polyclonal globulin smear. If you look at the one below, you can see that there's quite a dark band, and that's shown with another peak in the gamma globulin region. So that's an abnormal protein, the paraprotein or the M protein, that's quite characteristic of multiple myeloma. Now these bands, they tend to get measured as a percentage of the densitometry trace, and they are converted to gram per liter by multiplying it with the total protein of the sample. So that's how you get a numerical result. Now each laboratory, some of you might have had the experience of having blood tests performed at different laboratories, and you'll find that there's sometimes a bit of variation between laboratories. So each laboratory has a different, they might use a different method, they might have they might have different instruments. So each laboratory needs to establish its own reference intervals. So I've got the reference intervals here. So gamma globulins tend to be between 7 to 16 grams. And in this patient, you can see that it's obviously quite increased. So maybe it's sitting around 40 grams or so. And then we said that this patient had an IgG paraprotein or increased IgG protein. So that's because of the abnormal protein or the M protein. So let's look at how that is measured. So we've established now that this patient has a high gamma globulin. Now we need to type it, right? And we have a suspicion that it's an IgG because the total IgG is elevated. So now we would run what is known as immunofixation. It's all quite complicated. But basically, we have these different lanes. And on each lane, we would use an antibody against a specific type of protein. So IgG, IgA, IgM, kappa, and lambda. And we add a dye there. And then we run the patient's plasma on it. So you can see in this case, it's shown up quite nicely as an IgG lambda paraprotein. So that's how we know what the type of the paraprotein is. Now, so far what we have talked about is measurement of the intact immunoglobulin. So immunoglobulin is nothing other than antibodies, which we all have, but we have a mix of antibodies or polyclonal antibodies that help us fight infection. In patients with multiple myeloma, it's the same type of protein. So it's the M protein or the paraprotein that we need to look for. So far we've looked at the intact immunoglobulin, but all of these patients also secrete free light chains. So that's just this component here of the intact immunoglobulin. And because it's much smaller, it's a lot more sensitive in measuring disease burden in multiple myeloma. So most hematologists will also do a serum free light chain analysis. Now I apologize, the slides looks quite complicated, but I'll walk you through it. So on the x-axis, you've got kappa light chains. On the y-axis, you've got lambda light chains. Right? In the middle here, you've got a normal patient. So any of us, if we have a blood test done, you will find that the kappa and the lambda are quite balanced and they sit in the middle in quite low quantities. If someone has kidney failure, it's still a balanced production of kappa and lambda light chains, but it is present in higher quantities. Now, this is the case because free light chains normally get excreted by the kidney. So when you have kidney failure, you tend to have increased amounts of both kappa and lambda light chains, but it's fairly balanced. Now, in patients who have kappa multiple myeloma or lambda multiple myeloma, you can get a predominance of kappa light chains or lambda light chains. Now, this is particularly important in measuring response because often the intact immunoglobulin or the paraprotein will get depleted first, but the free light chains will still remain. So this is how we make a distinction between complete response and stringent complete response. So when the free light chains are normal, then you say that the patient has achieved a stringent complete response. Overall, serum free light chains are reported as kappa light chains, lambda light chains, and a ratio. So the ratio is quite important because it helps us to diagnose multiple myeloma. Serum free light chains are also quite important in diagnosing a condition as light chain multiple myeloma. So in some patients, you will not see an intact immunoglobulin at all, and you might only have light chains. So this is required as part of the diagnostic workup. So that is all I had on the protein studies. We've talked about the bone marrow. So the only other thing that is left to talk about in terms of investigations is bony disease. So we all know that multiple myeloma causes lytic lesions. And previously, we used a skeletal survey using X-rays. So we did X-rays on 4 regions of the body. And here you can see lytic lesions in the skull, in the pelvis, and in the long bones of the leg. But now we use more sensitive methods like CT scan, which you can see on the top left corner there, and a lytic lesion highlighted quite clearly. So we do a whole body CT scan, but we can also do an MRI, whole body MRI, or a PET CT scan. And depending on what you're looking for, and more importantly, what is reimbursed, different investigations tend to be used. I think across Australia now, whole body low dose CT is quite widely available. So I suspect a lot of patients on the call today would have had that done. But if it is possible, MRI and PET scan can be a bit more sensitive. So just to summarize, patients with multiple myeloma tend to have a full blood count performed, EUC, which is looking at renal function, liver function tests, which will tell you if the globulins are elevated, and calcium levels. In terms of the specific protein tests, we do serum immunoglobulins, so looking at IgG, IgA, and IgM levels. We then do serum electrophoresis to look for the M band or the paraprotein. And then we use immunofixation to type the paraprotein to tell us whether it's IgG or an IgA, and to tell us whether it's kappa or lambda. Serum free light chain is done at diagnosis and often at monitoring, but it may be used less frequently than the other investigations. Bone marrow biopsy is done at diagnosis, and scans for bone disease are again done at diagnosis. Now, when are all these investigations used? So certainly we want a full workup at diagnosis, and mostly it's blood tests, including all the protein studies at follow-up, usually every 3 to 6 months. Might be so there's no point in doing the investigations more frequently. And if relapse is suspected, then again, you might end up having the full workup done. So that was all I had. Thank you very much for listening. And if there are any questions, I'm very happy to take those.
Thank you so much for that presentation, Dipti. We do have one question from George. I have heard the term MRD negative. What does this mean?
Yeah. Thank you very much for that. So minimal residual disease is coming in quite a big way in the evaluation of multiple myeloma, and I haven't really covered that at all today. So we can use a number of different investigations to measure MRD. MRD basically means that even when you don't see any disease, obviously, we know that myeloma is an incurable disease. So there's bound to be small amounts of myeloma still present in the body. And there's different ways of looking at it. So you can use flow cytometry. You need to count a lot more cells. That's done on the bone marrow. And you can also use next generation sequencing, a much more sensitive method to look for MRD negativity. Basically, after treatment, if a patient has achieved MRD negativity, it means that they've had a very good response to treatment. And we expect those patients to do better in the long run and have recurrence of the disease after a longer period of time than patients who are MRD positive.
Thank you. Thank you again, Dipti, for joining us today. Again, especially taking time out of your weekend to be with us here and share your knowledge.